My name is Michael Burgos. I'm a starting strength coach and an occupational therapist. In my experience, most people don't know what occupational therapy is. So in case you didn't know, we are the progenitors of this functional revolution that you guys keep having to deal with. So for that, I deeply apologize. I'm here today to talk about work rehabilitation. It's an allied health subspecialty field that specializes in taking the injured worker who has completed some form of outpatient physical or occupational therapy and has not gone back to work, and we get them back to full duty work. I'll talk about some basic concepts, some OT terminology, try to reclaim some of my profession from you guys, and talk about the current paradigm of treatment, and I'll make some modest recommendations of how I think the field can be improved. So a lot of people get injured at work. In 2015, the Bureau of Labor Statistics reported that there were about 3.5 million non-fatal occupational injuries within the workplace. And this is constituent of private industry and government jobs. Now, if we assume that all of these injuries happen to a different person, or different people rather, then we can appreciate that that is a small percentage of the general population, but still that's 3.5 million people that over the course of 2015 at some point were not contributing to society in an effective or meaningful way. The medical management of these injuries are generally pretty linear. I'm not sure if that's showing up very well, but generally there's some kind of antecedent traumatic event, a big boo-boo, or the insidious onset of some kind of musculoskeletal malady, like a tendonitis or peripheral nerve impingement, a little boo-boo. Occupational health manages these injuries typically, but it can also be managed by emergency medicine. And if they're not able to stabilize the injury to the point that the person can return to work, there may be a referral to orthopedic specialists, where they decide to cut on you or not cut on you with surgery. In either case, there's a probable referral to physical or occupational therapy, and for the injured worker, the goal is most often return to work. Now, physical rehab has been discussed a lot on the Starting Strength website, and I'm not going to belabor a lot of the points discussed by these folks simply because they were developed and written by folks who are more read, experienced, and intelligent than I am. But everyone knows what a typical day in outpatient physical therapy looks like. There's lots of stretching modalities and interventions like that, and strength coaches look at those and think that must be just a method of increasing reimbursement. And for the most part, I agree. But I'm not here to talk about this phase of rehab simply because Rebecca Seigen's going to be talking about that in about 20 minutes. But also that a poorly cited but commonly quoted statistic suggests that about 90% of people heal up just fine within this phase of rehab within 6 months and return back to work full duty. However, the remaining 10% are stuck either out of work or on some kind of modified or transitional duty. And that's a problem because a strong predictor of long-term incapacity or chronic pain is time away from work following an injury. And that's a big problem, simply because there's a lot of cost associated with these injuries. So the person, the client, endures a cost simply because they're out of work, only receiving a fraction of their pay, and they still have bills to pay on top of that. The employer's down a revenue-producing team member, and the third-party payers are stuck having to cough up the rest of the insurance money for any medical services that are rendered. And annually, this is estimated to cost over $100 billion per year. And it's not just the financial cost that you have to consider. There's also a functional cost. And at this point, I can kind of listen real close and hear the collective disgust for the word functional. But I'm going to try and reclaim that somewhat. Injury decreases someone's ability to perform activities of daily living independently. And the ability to efficiently and accurately wipe your own butthole is a skill that is sorely missed when you can't do it. So thereby, injury introduces what's called occupational dysfunction. And there's a lot going on in that term, but I'm going to try to break it down from my lens. OT is not PT. we do not focus as much on structural pathologies, but we instead focus on increasing someone's ability to perform occupations independently. And work, participation in work, is only one component of someone's occupations. Occupations, then, are defined as valued, meaningful, and goal-directed activity that is central to a person's life roles. By that definition, you are what you do. What you choose to occupy your time with during the day constitutes who you are as an occupational being within the environment. So everybody in this room is a strength coach, and everyone can relate to what I'm about to say. If I walked over to Dr. Sullivan and stabbed out both of his eyeballs with a spork, he would probably go blind. Sorry, dude. But for a strength coach, blindness would introduce a whole hell of a lot of occupational dysfunction simply because I've robbed you of your coaching eye. This doesn't even touch the implications, literally. This doesn't even touch any implications for Dr. Sullivan as an author, as a physician, and as a human who has to eat stuff and drive. So, historically, OTs addressed occupational dysfunction with occupation-based, activity-specific rehab, meaning they just did the activity. And they did this with the developmentally disabled who were being deinstitutionalized from mental hospitals in the 1920s. So these folks were being reintegrated back into the community but had no useful skills other than crapping themselves and drooling. So OTs used activity specifically, like dressing, bathing, to get them more independent with those activities and thus make them more functional. But it is a mistake to generalize that method to everybody because activity-specific practice does not have to be the means to a more functional end. For an OT, it's not about the means, it's about the outcome. And the hallmark outcome of a functional intervention is one that makes someone who cannot become someone who can. And that's Chris Lane's mom deadlifting 150 pounds. She is more functional now than she was before she could do that, I guarantee it. So OTs used activity because they were working with the developmentally disabled. Biomechanical treatment does not have to look like this. For those with biomechanical issues, like our injured worker who's stuck out of work after they've finished physical therapy, their primary issue is that they cannot physically interact with the environment successfully to complete meaningful occupations like essential job tasks. So my argument as a starting strength coach is that if I were to increase someone's ability to produce force on those objects encountered within the environment, then I can directly impact their ability to interact with the environment and thus make them more functional. So I love this in the context especially of the injured worker. And I love this quote from the book that I accidentally showed earlier. While the bar is the most ergonomically friendly tool for lifting heavy weights, a 405-pound barbell deadlift makes an awkward 85-pound box more manageable. So again, these folks can't get back to work because their job is too physically demanding. We're talking about first responders. We're talking about construction workers, heavy equipment operators, and things like that. The U.S. Department of Labor put out the Dictionary of Occupational Titles, and that document describes just how heavy these jobs can be. So a useful parameter to identify first is the frequency and duration of the expression of the strength attribute across lifting, carrying, pushing, and pulling. The heaviest loads are only manipulated a third of the workday, up to a third of the workday, or an hourly, 1 to 20 minutes every hour, someone expresses X amount of force. So let's take a look at what heavy work looks like. Heavy work is defined as the occasional exertion of up to 50 to 100 pounds. I'm going to let that kind of sink in for a second, because I wouldn't describe that as necessarily heavy, but it could be awkward. Pardon me? The government. Yeah. Hey, good old government. But I wouldn't describe that as heavy because anyone that's ever lifted a stall mat knows that it's not heavy. It's just awkward. Very heavy work is described as anything over that parameter. So it could be 101 pounds. It could be 301 pounds. And as Rip kind of was asserting just a second ago, The government is only one of two things, usually, either wrong or ambiguous, and very heavy work is nice and ambiguous. So, everyone in this room is capable of taking the average working age Joe and getting them to lift this rather benign amount of weight for a set of 5 rather quickly, if not immediately, in some form or another. But I'm not equating a set of 5 to the occasional expression of force of up to 100 pounds. What I am subordinately asserting, though, is that if I were to increase someone's absolute strength well beyond this parameter, then that physical demand is suddenly not physically demanding, right? Physical and occupational therapy sometimes can't do that, and this is where work rehab enters to bridge that gap. So, work rehab has a lot of names in the literature, but the two most common that you'll encounter are work hardening and work conditioning. Now, the orthopedic section of the APTA describes work hardening and work conditioning in their clinical guidelines. And work hardening is a multidisciplinary program that uses real or simulated work activities to restore physical, behavioral, and vocational functions. Whereas work conditioning, is a conditioning program designed to increase systemic neuromuscular functions so that the client can return to work. So there's some differences between the two programs in that work hardening incorporates some psychological interventions, but in essence, the physical realm in which these two disciplines interact is essentially the same. They're trying to get the person to return to work by making them stronger. So how do these programs work? We'll take a quick look at work hardening. I'm not sure if that's showing up, but if you're that guy, and this is going to be a gross overgeneralization, but I think it'll drive the point home. If you're a wheelbarrow specialist, and your job, in your job description, is to shovel rocks into a wheelbarrow and walk from point A to point B and drop off those rocks, then the staple activity with which you're going to be advancing in your work hardening program is shoveling rocks into a wheelbarrow and walking from point A to point B. So if your clinic is not equipped to do these sorts of real work activities, then these activities can be simulated. One thing I don't have a picture of is a work simulation device called the BTE, or the Baltimore Therapeutic Equipment. And it's essentially this big machine that has an adjustable pedestal that offers electromagnetic resistance based on what you set it on. And it has a multitude of different attachments. So you could attach the ladder attachment, for example, for someone who's like a mechanic for a power company. You could put the ladder attachment on there and have them climb while standing there, because it's, you know, functional that way. Right, exactly, because it looks like the activity. But if you could also take that adjustable pedestal and turn it upright so the receptacle is facing vertically, and attach the cauldron attachment if you're a witch, and stir the pot while cackling maniacally. So if you don't have thousands and thousands of dollars to afford a BTE, though, you could use a more popular work simulation system. And I took this photo at a buddy's clinic, so I'll explain this here. Essentially what you do is you take that $350 17.5-pound particle board box and you load it up with ankle weights, usually in increments ascending from 1 pound to 10 pounds, and you have them lifted a multitude of different ways. And you have them put it on that $650 particle board adjustable shelf right behind you. Now, certainly this is harder than physical therapy or occupational therapy, but it's essentially just skill practice. That's our terminology for that sort of intervention. It's skill practice. But work conditioning focuses less on work simulation. I keep doing that, but work conditioning instead focuses on addressing specific factors like strength, power, endurance, and all in the effort to increase someone's work capacity. Now that sounds more like what we do, but in my experience, that's sort of not what happens. Based on what I've been relegated to in my own practice and what I've seen clinically at every work conditioning clinic I've ever been to, these programs are based around machines, Nautilus bodybuilder style kind of machines. Conditioning is done typically through low intensity steady state cardio, because if you do HIIT, they'll die. And it's just not as effective as it could be. I'm not going to say when or where this took place, but I was at a work conditioning clinic and I observed a young male firefighter, couldn't have been over 35, and he was sitting on a chest press machine, hitting, I don't know, high reps at a lower weight, and I couldn't see what he was lifting, the pounds that he was lifting, because there was a panel obscuring the pin setting. But at the top of his press, it kind of peeked out from behind that panel. And I noticed that the pin setting was on the second plate. And I'm not sure whether it was the clients or the therapist that told me this, but I found out eventually that he was 4 weeks into this rehabilitation. Now, I don't use machines anymore, but I used to. And I know, and I can guess that a chest press machine in a therapy clinic set to the second pin cannot possibly afford more than 45 pounds of resistance. And I know that any program 4 weeks in designed specifically to increase their work capacity, they should be pressing more than an empty barbell. Everyone in here can do this better, because work hardening is skill practice and work conditioning is essentially lightweight silliness with skill practice. If those two interventions, cardio and bodybuilder circuits, aren't enough to drive the therapeutic effect. Everyone in here can do it better. So a lot of time is being wasted then, but how much time? Work hardening typically costs per session 4 to 8 hours, a full day. Work conditioning takes anywhere between 2 to 4. Programs can be designed for up to 5 days a week, but some elect to choose 3, but in the effort to make it more functional and translate well to returning back to full duty work, they make it 5 days a week. And it can last anywhere from 2 weeks to 8 weeks. A common criticism of work rehab is that it's too expensive. That's why it's too expensive. Tell me, does the first day of starting strength, where you teach a ranked novice, injured or not, how to squat, press, and deadlift, does that take 8 hours? Does it take 6, 4? Maybe 2 if they're really dumb. But it doesn't take that long. And a lot of money and a lot of time can be saved by having these patients train instead of practice. So what's the solution then? We can't just stand here, point out problems, and make no effort at offering solutions. I think at the very least that well-coached barbell movements should be incorporated as staples into the work rehab setting. In my 1 hour, 2 hour guest lecture in college that specifically talked about everything I ever would have needed to know about industrial rehab or work rehab, it was suggested that not only do you incorporate a bunch of work simulation, but everyone should have some kind of core strengthening. In that case, I have a few practical suggestions. I recommend the squat, press, and the deadlift. And that's Sean Pang's client, by the way. Well, even if the program can't fully be implemented in the work rehab setting because therapy shoves work simulation down everyone's throat, then we do have evidence from Dr. Rakulia that suggests that even if the program only moderately simulates starting strength, that appreciable progress can be made. Everyone here is an expert at getting people stronger. And that's why I think starting strength coaches becoming more involved in these programs or developing them from the ground up can be very valuable in setting up starting strength as becoming recognized as healthcare and not just meatheads clanging around in a gym. Thanks.
Okay, I'm sure you know, the research suggests that strength programs are some of the few things that actually change incident of injury in the workplace. You're talking about work rehab. Are you working with any companies around prehab? Anybody who's proactively doing strengthening programs in anticipation of prevention?
So there are programs designed to do that. They're called post-offer employment testing programs. And basically what they exist to do is that they specify that someone that has to go to a physically demanding job, like a pipe fitter at a shipyard, for example, they need to be able to perform certain activities like lift 70 pounds occasionally, and you test them on those parameters according to the job description. I don't personally do POET interventions or anything like that, or it's abbreviated to POET, but there are programs out there that do that, definitely. Thank you. Yes?
So the comment about cost is real world to me. I run a shop of about 100 mechanics, and at any given time, 5 to 10 are on some version of work restriction or light duty. I bought a power rack and a B&R bar, and I have about 500 pounds of weight, but convincing people to do that as part of their rehab is obviously tricky from a liability standpoint. Are there any resources that I could refer to or have them take to their work therapy that would help make that case as something they could do to get back to work quicker?
Aside from starting strength? Basically all of the
something
articles.
that's accepted within your community.
A lot of the papers that were discussed this morning,
Yeah.
in terms of increasing strength as far as increasing health parameters and that kind of thing, would be largely helpful. And whenever Dr. Petrizzo's article about increasing strength, comparing common interventions versus ours, will be largely of great utility to you.
Do you get any pushback or have any issues with liability, dealing with some of the insurance companies or some of the medical professionals that?
Yeah.
Okay.
I get a lot of pushback. The docs absolutely refuse to put a rack in my clinic. So I'm stuck with that particle board box.
Yeah.
And I just have people perform basically what Rip outlined in his How to Pick Stuff Up video.
Yeah.
And I just have them do that in progressively increasing amounts because that's all I can do.
When are you going to get your own thing?
Working on that. Trying to nail down a few more credentials, and because right now I work in hand therapy, and I sit for the CHT exam in November. So if I pass that, then I'm even more of a unicorn than I already am. Yeah.
What started you? How did you decide that strength training would be the way to help your patients the most? And is it repeatable? Right? Can we get other people on board?
Yeah. The reason I decided that strength is the most important thing is very simply because I'm a disciple of starting strength. I absolutely believe that when you increase someone's strength, you increase their ability to do pretty much everything else. And from the context of understanding that the definition of function is occupational performance, being able to do stuff makes you functional. And following a musculoskeletal injury, you can't do stuff. And the problem is, it can be argued that it's a mobility issue. I can't reach my arm overhead, so I can't, do the thing up here. But if you train them to be able to express strength through movement all the way up to here, then all of a sudden they become more functional. And a lot of people argue with me on that because they just think that, barbells are for meatheads. But as it stands, I have yet to see when I increase someone's strength that they become dysfunctional. Does that make sense? Does that answer your question, actually?
Sort of. I was wondering what your exposure was, and it was like there's some watershed moment where you decided that I'm going to now incorporate starting strength. What brought you to the starting strength method to begin with, and is there any way to get that repeated with other therapists?
What brought me to starting strength? I was a vegan running 5'3", and I was about 185 pounds. It's just horrible. And then I went to Jordan's nutrition clinic in Hampton, Virginia, where everything that came out of his mouth opposed what I was currently doing. And so I decided to give it a shot, and that's how I got into starting strength. In terms of how I can facilitate that in other people, you have to challenge their thinking. because like Dr. Deaton was mentioning a moment ago, nothing has challenged me more professionally and intellectually more than being a part of this organization and understanding the philosophies and the founding principles that make it what it is. You're welcome.
When you propose putting a squat rack in the clinic and the physicians say no, do they give you a rationale beyond, you know, piss off, I'm the doctor and I said so? Do they give you some sort of rationale for why?
Yeah, so they think it's stupid most of the time. I actually
That's
sprained...
not a rationale.
It's not a rationale, no, but I sprained my wrist one time, hitting a deadlift on the floor too hard, and the reverb off the floor just tweaked the wrist a little bit. And so I got an x-ray just to make sure I didn't have an ulnar fracture.
All right, so here's my other question.
Sir.
For what's the average length of a work conditioning or or work hardening program?
Average length of stay ranges from 2 to 4 weeks, or 2 to 8 weeks, excuse me.
And how much does insurance pay, or how much do you get paid for a strength hardening or work conditioning program?
It depends on the amount of therapy units you sell per intervention.
Ballpark.
Gosh, I think we bill out maybe for the first 2 hours $150, and then maybe $75 on top of that for every additional hour. But what's reimbursed depends on what the insurance company feels like doing.
So you think the physicians have a rationale for saying no?
I mean, I know it. I know they don't. But
Interesting. So, so for the entire thing, it's like $200 you say for the first couple of hours.
Correct.
And $75 an hour thereafter, and
Correct.
4 to 8 hours a day, and 2 weeks, 2 to 4 weeks of therapy.
Correct.
And you could achieve superior results in the same period of time training somebody 4 hours a week, 5 hours a week.
Correct.
Okay. There's your rationale, right there.
Thanks. Any other questions at all?
I got one.
Sir.
In your dream clinic, other than applying starting strength, barbell movements, and things like that, do you carry anything else over from your current occupational therapy methods? Does that weighted box come with you? Are you training the wheelbarrow driver to shovel or anything like that? Any kind of, you know, unconventional training?
Right. I do think that there is some value in work simulation, but I don't think that it should be the principal intervention. I think by far the biggest thing that I can do is get them stronger. But, you know, a farmer's carry is a very difficult experience in and of itself because it's a different type of thing from the deadlift. But it still incorporates, you know, the arms are straight by your side, you're gripping something rather heavy, and you're trying to walk from point A to point B. Probably my work simulation would be more akin to what we do here, whereas if someone has to push or pull something, I might have them push the prowler. If someone has to perform something related to wheelbarrows or gripping something and going from point A to point B, it might be farmer's carries or something like that. But the, again, principal intervention would be the squat, the press, and the deadlift. You're welcome.
I was just going to let everybody know, in Texas, because we bill work conditioning, we average about $2,500 per client for 2 weeks. So it's $2,430 for 2 weeks. That includes an FCE, pre-FCE, and a post-FCE, and then 4 hours a day with transitioning from 2 to 4 hours. So that's what they're paying. So, and we use the barbell.
Fantastic.
We use the rack and the barbell for our conditioning patients. So
Fantastic.
just so people know.